All right, good afternoon, everybody, and welcome to our March 2026 bi-monthly Rural Health Clinic engagement meeting hosted by the Colorado Department of Healthcare Policy and Financing. Since we are now 5 minutes after the hour, I'm going to go ahead and get things kicked off. Let's see, next slide, please. And just as usual, wanted to reiterate our mission here at HICPUF, which is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Next slide. Okay, and to introduce myself, my name is Andrew Abalos. I'm the Facility Rate Section Manager here at the Department of Healthcare Policy and Financing, and I'll be presenting the material during today's meeting. Just as usual, these meetings are recorded, so if you have any questions for me, please make sure that you're speaking clearly and mention the hospital, clinic, or other entity that you represent. This will help us in the event that we need to follow up after the meeting to address any concerns that you bring up. And additionally, since this meeting is recorded, we will post this recording to our website, which will allow you to forward this meeting to others that may have missed it. So this slide just shows some information on the timing of these meetings, both reiterating the webinar link and the conference line information. And as you may note, our next meeting is currently scheduled for April 30th at the same time of day. And to reiterate a little bit more about the intent of these meetings, we have been working to establish a more active forum by which we at the department can hear directly from the RHC community regarding the issues that they face. And while we at the department have prepared material for today's meeting, we do want to invite others to email us and let us know topics that might be of interest, just so we can collaborate and just create agendas together with the RHC community. I'll have more on this later on in the presentation. But I'll go ahead and move to the next slide, please. So here's our agenda today. We do have a few educational topics as usual. I'll have more on that later too. And also some reminders on the processes relating to rural health clinic payment. Stay on here for just a moment. And then, all right, let's go to our next slide, please. So first, for some exciting news, we have recently filled our vacant FQHC RHC rate analyst position. So please welcome Marcella Kuzmiak to our team. You'll be seeing her name on lots of RHC letters and things moving forward, including these meetings. So all of that said, moving forward, she will be the point of contact for matters relating to RHC rates. But also for a little while there, please include me on your emails. We're just excited to have some additional help on board. So once again, welcome to Marcella. And next slide, please. All right, so again, this shouldn't be different from some of the topics we've gone over. I just want to preface a lot of this by saying this will likely be our last iteration of reviewing these rate methodologies in case there is interest. We do plan on doing some revisions to our RHC site to include this information to hopefully make this less redundant, but just wanted to still go over this since we still get a lot of questions on these. So again, these are intended to be some resources and educational tools for how we set rates for both our freestanding or independent RHCs, as well as the hospital-based or provider-based RHCs. So beginning here with the freestanding RHCs, we set the rates that are the higher of the prospective payment system, or PPS rates that are established by BIPA in 2000, or the alternative payment methodology rate, which is the Medicare upper payment limit for rural health clinics. Let's see, next slide, please. So for new freestanding RHCs, the interim rates are set as the average of other freestanding RHC rates within that RHC's regional accountable entity region. And so we follow a very similar process for establishing the PPS rate for those new RHCs, which is relying on the average of other freestanding RHC PPS rates within the same ray. Next slide, please. So in general, we do see the freestanding RHCs being assigned the Medicare RHC UPL rates, which are listed here by calendar year. This table also shows the current trajectory of the freestanding RHC rates through the calendar year 2028. And so we are now in 2026. I've highlighted the current rate for these RHCs here, which is now active in our claims processing system. So I'll have more on that later, but just want to stay on this for a moment as we'll be using these rates for at least the next couple years. All right, and next slide, please. So I'll just go ahead and briefly go over the methodology for the hospital-based RHCs, or again, provider-based. Similar to the freestanding RHCs, the encounter rates are the higher of the PPS rate or the APM rate. PPS rates are calculated the same, but here the APM rates are based on actual costs. For the APM rates, each year, PPS rates are calculated and compared to the most recent audited and finalized cost per visit from the Medicare cost reports, and these rates are used to set the current year interim rate. After an RHC's Medicare cost report has been audited and finalized, the department performs a reconciliation for the services provided. Reconciliations are calculated based on the comparison of the number of visits that are reported and the difference between the interim and finalized rates for the year the cost report covers. It's going to result in payments to these RHCs or recoupments if necessary, again, depending on the comparison between interim and finalized rates. Next slide, please. So to provide a little more insight into how all of this works, the department works with its auditor, currently Myers and Stauffer, to obtain the finalized rates towards the beginning of each calendar year. Myers and Stauffer utilizes CMS's Healthcare Cost Report Information System, or HCRIS, database to obtain this data, usually incorporating the data load into HCRIS that happens during the final quarter of the prior calendar year. So for example, I believe that CMS updates this database, I believe sometime in November or December of 2025, and that is the database load that Myers and Stauffer will use to determine which RHCs will be having their rates adjusted and the reconciliations that we will perform. So during that process of determining the hospital-based RHC rates, Myers and Stauffer provides the department with the finalized rates from those cost reports and the comparisons to the PPS rates. And the department will load the higher of the PPS and most finalized rate into its MMIS effective for the calendar year it received the data. Then we perform the calculations for the newly audited and finalized cost reporting period. When it has completed its calculations, we clear the payments through our leadership and we send the reconciliation letters. So I have more specifics on the exact timing since we are currently in the process of doing this, but before I move on, just wanted to open it up and see if there's any general questions on the process. Okay. Not seeing anything, we'll go ahead and move to the next slide. All right, so just for more specifics on the more recent processes here. So the reconciliations, again, we're basing that off of historic claims data, and what those come along with are generally, once we've completed those analysis, are letters describing those one-time lump sum payments to reconcile to those finalized and rates. So for last year, those rates that we received, we were unfortunately unable to complete them just due to the staffing shortages we recently talked about. But the previous year's reconciliations were aggregated into the 2026 work. We actually sent out the rate letters for the calendar year 2026 rates from our auditor. Those were distributed in late January, early February. So you should have all received those. But the related reconciliations are currently undergoing their final clearance steps with our leadership. So we are actually very close to being able to get those reconciliation letters out. And again, that will incorporate those audited finalized cost reports that we received in both 2025 and the most recent ones in 2026. So we are very close to being all caught up with this. And then next slide, please. Okay. So we did in our previous meetings talk about having a broader RHC rates posting on our RHC website. We believe that this will have a couple of functions. Number one, it adds a little bit more transparency so that those rates will be public. Again, we really think of these rates as something that already exists publicly as found via the HCRIS cost reports. So we Don't foresee any issues with making that data more transparent and accessible. We often get questions about this within the department, so we think that this will help ease some of the administrative work we have to do in responding to those. But in addition, we believe that this may serve as a function to ensure that the regional accountable entities are also using our updated rates, so we can have an additional posting by which those can be verified. Now, all of that said, we're still trying to figure out how that all might work. So in the meantime, we are still updating the managed care site that we use for the managed care entities and the rates to be able to validate the RHC payments or the rates that we're currently using. And we're working on some final elements of it, but we have the most of the RHC rates are now updated in that system. I believe that the only remaining work might have to do with some RHCs that we still do not have finalized rates for, but those are very few. But all of that said, for a majority of RHCs, we have provided the managed care entities with the updated rate information on February 6th. So if you're still encountering some discrepancies between rate payments based off of some outdated rate information, please let us know. We do want to make sure that they are paying at the appropriate rates. So you can reach out to either Marcella or myself on that, and our contact information is posted at the end of this presentation. Okay, and next slide, please. Okay, so more on the fee for service side of things, just a few updates on the 2026 RHC rates. Again, we just have a reiteration, these couple of top bullets here, showing what the methodology is we use and how we are applying those rates. So we wanted to implement those rates as soon as possible upon receiving those updated rates within our MMIS, just to minimize the volume of claims adjustments. We did complete the RHC rates being loaded into our claims processing system, and we did get the claims adjustment completed as of the financial cycle a couple weeks ago. So for any of those 2026 claims that have come through for service dates within 2026, they should now be paying on the appropriate rate, and we should have had all the claims adjusted so that way they paid to those rates as well. Similarly, for the freestanding RHCs, we were a little bit more fast on those ones, just there's a smaller volume of those within our system. Those rates have been completed in the system. They should be paying at the appropriate rate, and we have retroactively adjusted all those claims such that they are paying at the appropriate rate as of the February 6th financial cycle. Okay, and then next slide, please. All right, so those are some of the more operational updates, but just wanted to remind the RHC community we do have a scope of service rate adjustment process in place. This is compliant with BIPA, as mentioned earlier, which will allow for adjustments to an RHC's PPS rate whenever a valid change in the scope of service takes place. So the website in this slide contains both the instructions and application for requesting a change in scope of service, and those instructions contain more guidelines for what is and what is not considered a valid change in the scope of service. So this is something that you are interested in. I highly recommend you review the guidelines on the site. We don't receive a lot of questions on this, but if you do have any questions, feel free to reach out to Marcel and myself, as mentioned earlier. Okay, and next slide, please. All right, so we have a little more information here about our managed care accuracy audit process. Again, going back to what we were talking about earlier, the managed care entities are required to reimburse RHCs at an amount no less than the encounter rate set by HCPF. RHCs can participate in this process in a couple of different ways. First, if an RHC does not submit quarterly data, then HCPF will determine that the facility has been paid in full. Second, the facility can notify HCPF that they have been paid in full, which makes our team which handles these payments lives easier. And then the last way is facilities can submit data indicating that payment is still due. We'd like to emphasize that it may be optimal to reconcile the data with the relevant managed care entity prior to the submission of going through this process, but nonetheless, this is a process we have to ensure that RHCs are getting paid their full amount. So really, this serves as a call to attention on a potentially missing revenue stream to RHCs from the raise, which is why this is listed here. And while we don't have Kennedy present during today's meeting, Kennedy has agreed to have her information on this slide as a point of contact for this process. So if you'd like to know more, I encourage you to reach out to Kennedy. Okay, and next slide, please. Actually, I apologize. I'm realizing that the next meeting is actually scheduled in April, so April 30th, but we'll correct that when we post it. But for future meeting topics, we are certainly willing to, like I said at the top of this meeting, hear from the RHCs, think about what's interesting or like what we want to hear about regarding the fee for service payments. If there's anything we should be considering in adjustments to our rate methodology or any more transparency that we can lead into the processes around that. So just as usual, if you do have any topics you'd like to see brought up in these meetings, I encourage you to email us with at least a couple of weeks of advance notice, just to make sure we have adequate time to prepare and maybe bring on the appropriate subject matter experts for these meetings. Okay. And next slide, please. So this is the end of our prepared material. I wanted to open it up to see if anybody had any questions, comments, solutions on anything that's been discussed today. All right, and seeing it's a small audience today, so I'm not seeing anything in the chat. Like I said, we do have our contact information at the end of this slide, so if nothing's immediately coming to mind, please feel free to reach out. Let's go ahead to the next slide, please. All right, so here's our contact information. For rates-related matters, you want to contact myself, Andrew, and Marcella on the left. For the policy-related matters, you probably want to contact Morgan and Janelle. But otherwise, we are all set on today's material. So feel free to reach out in the meantime if anything comes to mind. Otherwise, we'll plan to see you at the end of April. Thank you for joining, everybody.